In today's lecture, we will discuss the general principles of antimicrobial therapy. So, specific learning objectives for this lecture. First of all, definition of chemotherapy and antibiotics, then historical approach, then we have to classify the antimicrobial agents based on the mechanism of action, principle of choice of antimicrobial therapy, then the antibiotic resistance, superinfection, antimicrobial combinations, and lastly, prophylactic use of the antimicrobials. Now, first of all, definition. Antimicrobial drugs are the greatest contribution of the 20th century to the therapeutics. Means after evolving of the antibiotics, we can cure the diseases, right? So antibiotics are the substance, or we can say any chemical substances which is obtained from microorganisms which selectively suppress the growth or kill other microorganisms at a very low concentration. How will you define antibiotics? Antibiotics, they are any chemical substance obtained from microorganism which selectively suppress the growth or kill, either they suppress the growth or kill the other microorganisms at a very low concentration. Now, chemotherapy. Chemotherapy means treatment of infectious diseases. What is chemotherapy? Chemotherapy means treatment of infectious diseases or malignancy. It includes both infectious diseases as well as malignancy with drugs which destroy microorganisms or cancer cell with minimal damage to the host tissue. In case of chemotherapy, there is a treatment of infectious diseases or malignancy with drugs. In case of infectious diseases, we have to kill or destroy microorganisms, or in case of malignancy, we have to destroy or kill cancer cells with minimal damage to the host tissue or with minimal damage to the recipient. Now, historical approach. In the history, Pasteur and Joubert, they were the first scientists who identified that one microbe could destroy other microbe. Right? Now, Paul Ehrlich, who was the father of modern chemotherapy, he showed that certain dyes like methylene blue can be used in malaria, arsenical compounds can cure syphilis and sleeping sickness, and he got Nobel Prize for his work on chemotherapy. After that, there is a discovery of penicillin. We all know that Alexander Fleming, sir, discovered penicillin in 1928. That time he was studying different variants of staphylococci, but particular fungus was contaminating one of the culture plates of the staphylococci. One of the culture plate of the staphylococci, that one particular fungus was contaminating, and that name of the fungus was the Penicillium notatum. Penicillium notatum, as you can see, there is a culture plate, and on that culture plate he was growing various different strains of the staphylococci, but one particular fungus was contaminating that culture plates, and the name of the fungus is the Penicillium notatum. That produces chemical substance which inhibit the growth of other microorganisms, and that chemical substance was the penicillin. That chemical substance was penicillin, and that's how penicillin was discovered. And from that, there is a beginning of the golden era of the antibiotics, we can say that. From the discovery of penicillin, there are number of antibiotics, antimicrobial agents have been discovered, and we can say that that was the beginning of the golden era of the antibiotics. Now, how will you classify them? On the basis of chemical structure or on the basis of mechanism of action? On the basis of chemical structure, sulfonamide, quinolone, beta-lactam antibiotics, tetracycline, aminoglycosides, macrolides, it is very difficult to classify them on the chemical structure, because chemical structure is very difficult and it is highly impossible to remember. So, based on the mechanism of action, we classify them. Antimicrobial agents, we classify them on the basis of mechanism of action. Cell wall synthesis inhibition, the drugs which acts by inhibiting cell wall synthesis, penicillin, cephalosporin, vancomycin, cycloserine, bacitracin, they particularly act on the cell wall synthesis inhibition. Then there is a leakage of the cell membrane. Cell wall is different, cell membrane is different, so there is a leakage of the cell membrane. So antifungal drugs, particularly antifungal antibiotics like amphotericin B, ketoconazole, azoles, polypeptide like colistin, griseofulvin, means leakage of the cell membrane is the mechanism of action of the antifungal drugs. Protein synthesis inhibition, by inhibiting the protein synthesis, drugs like tetracycline, macrolides, chloramphenicol, clindamycin, they act by inhibiting protein synthesis. Then misreading of the mRNA code, misreading of mRNA code, and ultimately there is the inhibition of the protein synthesis, aminoglycosides. Inhibiting the DNA gyrase enzyme, inhibiting the DNA gyrase enzyme, fluoroquinolones, and antimetabolites by inhibiting the folate synthetase and folate reductase, the drugs like sulfonamide and dapsone. So these are the mechanism of action, different mechanism of action, means we can classify them based on the mechanism of action. Yes, this is what we have just seen. First of all, this is what you can see, the cell wall synthesis inhibition. Cell wall synthesis inhibition, the drugs like penicillin, cephalosporin, carbapamins, monobactams, vancomycin, bacitracin, what they do? They inhibit the cell wall synthesis. They inhibit the outer layer or cell wall synthesis. Now, inside that, as you can see, there is a thin layer, and that thin layer is the cell membrane. So, cell leakage of the cell membrane. Most of the antifungal drugs acts by this mechanism, leakage of the cell membrane, like polymyxin B, azoles, amphotericin B, colistin. All these drugs acts by leakage of the cell membrane. Then next is the inhibition of the protein synthesis inhibition. In protein synthesis inhibition, there are two subunits. Either there is a 30th subunit and either there is a 50th subunit. Protein synthesis inhibition, 30th subunit and 50th subunit. The drugs which acts on the 30th subunit like tetracycline and aminoglycosides by inhibiting 30th subunit, and by inhibiting 50th subunits, the drugs like macrolides, clindamycin, linezolide, chloramphenicol, and streptogramins. These are the drugs which acts on the 50th subunit of the protein synthesis. Then quinolones or fluoroquinolones, particularly they act on the enzyme DNA gyrase. They particularly act on the enzyme DNA gyrase. Rifampicin, antitubercular drug, the drug which acts on the particular enzyme that is called as the RNA polymerase. The drug rifampicin acts on the RNA polymerase. Right? Now, antimetabolites, as you can see, the sulfonamide, trimethoprim, dapsone, these are the antimetabolites or folate synthesis inhibitors. Folate synthesis inhibitors, they particularly act on the enzymes, or they are the folic acid synthesis inhibitors, we can say that. So this is how we classify them on the basis of mechanism of action. We have just seen, and this is how we have to classify them. Mechanism of action of antibacterial drugs, drugs which inhibit the cell wall synthesis, drugs which inhibit the protein synthesis, drugs which cause leakage from the cell membrane, drug which causes misreading of the mRNA code and that will affect your permeability, drug interfere with the DNA function by inhibiting RNA polymerase, drugs which inhibit the DNA gyrase enzyme, and drugs which interfere with the metabolism, folic acid synthesis like sulfonamide, sulfone, trimethoprim, pyrimethamine, para-aminosalicylic acid, metronidazole. So this is how we classify them. Now the important one, we classify these antimicrobial agents on the basis of bacteriostatic and bactericidal. Now what is meant by bacteriostatic? As the name suggests, bacteriostatic, they inhibit or suppress the growth and replication of the bacteria and thus limit the spread of infection. Bacteriostatic, what they are doing? They inhibit or suppress the growth and replication of bacteria and thus they limit the spread of infection. What they do? They limit the spread of infection. The drugs like sulfonamide, tetracycline, chloramphenicol, macrolides, linezolide, what they do? Or clindamycin, ethambutol. Ethambutol is the only antitubercular drug which is bacteriostatic in nature. All other antitubercular drugs are bactericidal. All other antitubercular drugs are the bactericidal. Right? Now they are adequate in uncomplicated infection. We can say that bacteriostatic drugs, they are adequate or enough or sufficient, we can say, in uncomplicated infection, because what they do, they inhibit or suppress the growth and replication of the bacteria, and thus they limit the spread of infection. So we can say that they are adequate in uncomplicated infection. Then next is the in immunocompromised individual. They are preferred in immunocompromised individual. Means in case of immunocompromised individual, bacteriostatic drugs are given. Then concentration and combination therapy. When two bacteriostatic drugs, when they are combined together, that drug becomes bactericidal. Or when some drugs they are used in high concentration, that bacteriostatic drug may act like bactericidal. That is the difference. When you are combining two bacteriostatic drugs, that drug may act like bactericidal, or when you are using that same drug which is bacteriostatic in nature, but you are using that drug in a higher concentration, that drug will act like bactericidal. That means combination and concentration will matter. Whether that infection is uncomplicated or complicated or mixed infection, then what drug you have to give, that will matter. Then in case of immunocompromised individual, bacteriostatic or bactericidal, which drug you have to give, that we have to decide. Means these are the various criteria for the efficacy of antibiotics. Now bactericidal means they kill or destroy the microorganism. So irreversible damage to the multiplying bacteria, hence total number of viable microorganism decreases. What happens in bactericidal? They kill or destroy microorganism. In case of bacteriostatic, they inhibit or suppress the growth and replication and they limit the spread of infection. But in case of bactericidal, they directly kill or destroy the microorganisms so that irreversible damage to the multiplying bacteria, hence total number of viable microorganism decreases. So examples like beta-lactam antibiotics, aminoglycosides, quinolones, antitubercular drugs, all antitubercular drugs are bactericidal except ethambutol. Except ethambutol, ethambutol is a bacteriostatic. Now spectrum of activity. Spectrum of activity means activity against type of organism. Antibacterial, antifungal, antiviral, antihelminths, antiparasites. But that spectrum of activity is further classified like narrow spectrum, broad spectrum, wide spectrum. The drugs which effective against only gram positive or they are effective against only gram negative, we call them narrow spectrum. Like penicillin is effective against gram positive. Aminoglycosides are effective against gram negative. So we can call them narrow spectrum. They are effective against only gram positive or gram negative. We can call them narrow spectrum. But broad spectrum, the drugs which are effective against gram positive, gram negative, apart from that, they are effective against other microorganisms like Brucella, Legionella, and other intracellular, extracellular microorganisms based on the spectrum of the activity. Based on the spectrum of the activity, we can classify them. We can classify them on the basis of that spectrum. So that there is one more classification. There is called as a wide spectrum. Wide spectrum means in clinical practice we use the term wide spectrum of activity. Means not only effective against gram positive or gram negative, they are effective against other microorganisms also. So the ampicillin, we can say that it is the ampicillin or amoxicillin. These are the wide spectrum activity. They show the wide spectrum activity. Now sources of antibiotic. Sources of antibiotic mostly natural, semisynthetic and synthetic. Natural, they are mainly obtained from the fungus, bacteria, actinomycetes. Like penicillin, they are obtained from the Penicillium notatum. Like streptomycin, these are the natural antibiotics. Semisynthetics, these are chemically altered natural compounds like ampicillin, amikacin. These are the chemically altered natural compounds. And synthetic compounds like norfloxacin, moxifloxacin, they are chemically designed in the laboratory. They are chemically designed in the laboratory. So sources of antibiotics, as you can see here, we have classify on the basis of the fungus, bacteria, actinomycetes. Fungus from the penicillium, we know that it is obtained from the Penicillium notatum, cephalosporin from the cephalosporium, griseofulvin from the griseofulvum. Bacteria like polymyxin B, it's obtained from the Bacillus polymexa, bacitracin from the Bacillus licheniformis, actinomycetes like aminoglycosides, tetracycline. And these are the particular microorganisms from which the drug is extracted, like Bacillus subtilis, bacitracin, Bacillus polymixa, polymyxin, Streptomyces nodosus, amphotericin B, Venezuela chloramphenicol, Aurophacians, tetracycline, Erythromycin, erythrus, Streptomyces griseus. So these are the different microorganisms from we can extract all these antibiotics. Then next is the minimum inhibitory concentration and minimum bactericidal concentration. Minimum bactericidal concentration. Now MIC or minimum inhibitory concentration, it's the lowest concentration of an antibiotic which will prevent the visible growth of bacteria after 24 hours of incubation in a microwave culture plates using serial dilutions of antibiotic or disc diffusion method. What is meant by MIC? MIC is the minimum. Minimum means lowest concentration of an antibiotic. Minimum or lowest concentration of an antibiotic which will prevent the visible growth of microorganism or which will prevent the visible growth of bacterium after 24 hours of incubation in what? In microwave culture plates by using the serial dilutions of an antibiotic or disc diffusion method, and we can call it as a MIC. Minimum bactericidal concentration means concentration of antibiotic which kills 99.9% of the bacteria. We can call it as a minimum bactericidal concentration. So this is the minimum inhibitory concentration of the test which determine antibiotic activity of a material against a specific bacteria. What they determine? They determine the antimicrobial activity of a material against a specific bacteria. So we can call it as a minimum inhibitory concentration. So the most commonly employed methods are the tube dilution method or agar dilution method. Test products that are not clear or precipitate the growth media are tested by agar dilution method, which is about same as the tube dilution method except dilutions are plated on agar. These are the various methods like tube dilution method or agar dilution method. As you can see here, we have to inhibit the E. coli by using the drugs which are effective against the E. coli. Then post-antibiotic effect. After a brief exposure, if the organism is placed in the antibiotic-free medium, after brief exposure, the antibiotic is placed in the antibiotic-free medium, it will start again to multiply, but after a lag period which depend on the antibiotic as well as the organism. What they are saying, after a brief exposure, if the organism is placed in the antibiotic free medium, it will again start to replicate or multiply, but after a lag period which depend on the antibiotic as well as depend on the microorganism. So what is that lag period? Lag period is the time required for the reattendment of the logarithmic growth. What is lag period? Lag period is the time which required for the reattendment of the logarithmic growth. So persistence of an antibiotic effect observed long after serum concentration has fallen below the MIC. Means that antibiotic will remain effective even after the serum concentration has fallen below the minimum inhibitory concentration. We can call it as a post-antibiotic effect. Though the plasma concentration of the antibiotic has fallen below the MIC or minimum inhibitory concentration, still that drug or still that antibiotic will show its effect. We can call it as a post-antibiotic effect. Persistence of the antibiotic effect observed long after serum concentration has fallen below the MIC. So long dose dependent post-antibiotic effect is seen with the drugs like fluoroquinolones, carbapenems, aminoglycosides, rifampicin. Now what are the various reasons for this post-antibiotic effect? Why these drugs are showing effect even after the plasma concentration falls below the MIC? Because there is a presence of drug in the periplasmic space or at binding site. There is presence of drug in the periplasmic space or at the binding site. Now what is the periplasmic space for this? As you can see, this is the gram negative, this is the gram positive. But here you can see there is a periplasmic space and there is a deposition of the drug on the binding site or at the periplasmic space. So that drug will remain effective even after the plasma concentration falls below the minimum inhibitory concentration. Now concentration dependent killing or time dependent killing. Concentration dependent killing, inhibitory effect depend on the ratio of peak concentration by minimum inhibitory concentration. Means if you are increasing concentration, more and more bacteria will be killed. That is the concentration dependent killing or concentration dependent inhibition, or better name is the concentration dependent killing. If you increase the concentration of the drug, more and more bacteria will be killed. Inhibitory effect depend on the ratio of peak concentration by minimum inhibitory concentration. Drugs like aminoglycosides, fluoroquinolones and metronidazole, rifampicin, they act by the concentration dependent killing. Now time dependent killing, length of the time the concentration remains above the minimum inhibitory concentration, so increase dosing frequency or you have to increase the half-life of a drug. Means length of the time the concentration remains above the MIC. The length of the time the concentration remains above the minimum inhibitory concentration, means you have to keep the concentration of the drug above the MIC for a longer period of time. That is the time dependent killing or time dependent inhibition. If that concentration will remain above that particular MIC, that more and more bacteria will be killed, more and more microorganisms will be killed. That is called as the time dependent killing. Drugs like beta lactams, glycopeptides, macrolides, these are the drugs which acts by acting on the time dependent killing. Then drug factors like spectrum of activity that we have just discussed: narrow spectrum, broad spectrum, wide spectrum. Like, means drugs which are effective against gram positive, gram negative, or other intracellular or extracellular microorganisms. Then type of activity like bactericidal or bacteriostatic. Sensitivity of the organism, whether that organism is sensitive or resistance, it shows resistance. Then pharmacokinetic profile. For optimum action, antibiotic has to be present at the site of infection. Means there is a presence of drug or antibiotic at the site of infection at optimum concentration for adequate time. Pharmacokinetic profile of the drug, it should reach to that particular site of infection at optimum concentration for the adequate time. Host defense mechanism that reduces the antibiotic requirement. Host defense mechanism means that particular individual is immunocompromised. If that particular individual is immunocompromised, in that particular case we have to use the bactericidal drugs. But if that particular person is showing host defense mechanism is very strong, then you can use the bacteriostatic drugs also. That will reduces the antibiotic requirement. If your host defense mechanism is very strong, that will reduce your antibiotic requirement because it will act by its own. Relative toxicity, less toxic antibiotics are preferred because in definition we have seen minimal damage to the host, minimal damage to the recipient. So less toxic antibiotics are preferred. Route of administration, less severe infection, you can give the antimicrobial agents orally. In severe infections, you have to give IV antibiotics. The factors which affects the antimicrobial agents, like age, pharmacokinetics affected, and antimicrobial agents produces age-related side effects. Age-related side effects. For example, chloramphenicol causes gray baby syndrome in the premature babies or neonates. Why it causes gray baby syndrome? Because in premature infants or premature babies or neonates, there is a deficiency of the enzyme which metabolizes chloramphenicol. There is a deficiency of enzyme which metabolizes chloramphenicol, so that chloramphenicol will get accumulate in your body. Plasma concentration increases, and that's why that chloramphenicol will get accumulate in your body, and there is a occurrence of gray baby syndrome because the hepatic functions are not that much developed, or there is a deficiency of that enzyme which metabolizes the chloramphenicol. Sulfonamide can cause kernicterus. Sulfonamide can cause kernicterus because of the plasma protein binding. Because of the plasma protein binding, it will displaces the bilirubin. Bilirubin displaces that sulfonamide, so it may cause kernicterus. Aminoglycosides can cause auditory nerve toxicity in the elderly people. It may damage your auditory nerve, so there is a problem with the hearing. Renal and hepatic dysfunction. In the renal failure or hepatic failure, you have to adjust the dose of the drug according to need. Then local factors like presence of pus, necrotic materials, foreign body like biofilm production by the bacteria and fungi, hematomas, low pH, anaerobic environment, penetration of the barrier. All these are the local factors which are going to affect the effect of the antibiotic. They are going to affect the action, or they are going to affect the efficacy of the antibiotic. Then pregnancy, most of the antimicrobials are not safe except penicillin, cephalosporin, tetracycline, aminoglycosides are contraindicated. Means penicillin is safe, quite safe as compared to the other drugs like cephalosporin, tetracycline, aminoglycosides. They are contraindicated in pregnancy because they are teratogenic in nature. Now tissue penetration. Tissue penetration, antibiotics are often administered far away from the site of infection. They are administered far away from the site of infection, but they should penetrate that barrier and they should reach at the site of infection. They should reach at the site of infection by penetrating that particular tissue. To be effective, each antibiotic has to get where the pathogen is, to penetrate to the infected compartment. So therefore, in choosing antimicrobial therapy for the therapy, the crucial consideration is whether the drug can penetrate to the site of infection or not. Means in case of what they have given the example, CNS, penicillin G has poor CSF concentration and integrity decreases during inflammation. If you are using for meningitis, if you are using penicillin G for the meningitis, what happens? Penicillin G has very poor CSF concentration and integrity will decrease during inflammation. Cefuroxims, ceftriaxons attain very high CSF concentration, means if you are using that drug for meningitis, it should reach to the cerebrospinal fluid, it should reach to the, means it should cross the blood-brain barrier and then it should reach to the cerebrospinal fluid, means it should achieve that effective concentration in that particular cerebrospinal fluid if you want to treat the meningitis. That means tissue penetration is very much important. Means to be effective, that antibiotic has to get where the pathogen is. Antibiotic has to get where the pathogen is, means to penetrate to the infected compartment. You have to penetrate that particular barrier. That drug should reach at a therapeutic concentration at the particular site of infection. Then there is a gene transfer, they are saying. Insertion techniques. Okay. Now, gene transfer, or before that, drug resistance. Drug resistance, and in that there is a gene transfer. Now, antimicrobial resistance, drug fails to reach at its target. Example, alter permeability, drug is inactivated, means penicillins are inactivated by lactamase and target is altered, right? So there is a development of resistance. So type of bacterial resistance, there is a natural resistance, there is a acquired resistance. So some microorganisms are resistant to certain antimicrobial agents and it is genetically determined. So we can call it as a natural resistance. Means Pseudomonas is insensitive to penicillin G, right? Gram-positive cocci are not affected by streptomycin. So these are the natural resistance. Acquired resistance means development of resistance in a previously sensitive microorganism due to use of an antimicrobial agent for a certain period of time. So we can call it as a acquired resistance, right? Means initially it is sensitive, but later on there is a development of resistance in a previously sensitive microorganism. And nowadays it's a major clinical problem. So gene transfer is one of the mechanism of resistance. So what is gene transfer? There are three processes: conjugation, transduction and transformation. Conjugation through direct contact with the sex pilus. There is a enterococci contains host range of conjugative plasmid Penicillin resistant Haemophilus, E. coli, they are resistant to the streptomycin, and they occurs through the conjugation. There is a direct contact with the sex pilus. So this is one of the reason for the resistance. Transduction, transfer of the resistance genes through an bacteriophage. What is transduction? Transduction is the transfer of the resistant gene through the bacteriophage. The bacteriophage is nothing but the virus which infect the bacteria. Virus which infects the bacteria, that is called as the bacteriophage. So transfer of resistance gene through bacteriophage, example is the staphylococcus to the rifampicin. Then next is the transformation. Resistant bacteria released free DNA which carry resistance into the environment by other bacterial cells. So penicillin G is resistant in pneumococci because of this transformation, means resistance bacteria released free DNA which carry resistance into the environment by other bacterial cells. Now, these are the different reasons for having resistance, for showing resistance. There are the efflux pump. As you can see, there is a efflux pump. Just 1 minute. What happens to these slides? Yes. As you can see here, there are the efflux pump. Efflux pump, so that drug will get effluxed. That drug will get expelled from the pump. We call it as a efflux pump. There are a number of efflux pump, and because of that, drug cannot accumulate inside the bacteria. Drug cannot accumulate inside the bacteria, so that that particular microorganism will show resistance to that particular drug. The drugs like fluoroquinolones, aminoglycoside, tetracycline, beta-lactams, macrolides, they have that efflux pump mechanism, so that that all drug will get expelled from the microbacteria, microorganisms, so drug will not be effective. Then inactivation of the enzymes. Inactivation of the enzymes like beta-lactams, aminoglycosides, macrolides. So what they do, they will inactivate the enzymes. They have the enzymes which will inactivate the drug. Then blocked penetration. That drug cannot enter inside the bacteria. That drug cannot enter inside the bacteria because of some mechanisms. It will block the penetration of the antibiotic like beta-lactams, tetracycline, fluoroquinolones, or there is a alteration of the target modifications like fluoroquinolones, rifampicin, vancomycin. They will alter the target modifications. These are the reasons for the resistance. Transposable elements are of three general types. First is the insertion sequence, transposons, transposable phages. So insertion sequence and transposons are the important for resistance. Now what is meant by insertion sequence? These are nothing but the short segment of DNA which encodes for the enzymatic functions. Transposes and resolvases for site-specific recombination and with inverted repeat sequence at the other end. There is a short segments of DNA which encodes for the enzymatic functions. Means there is a problem with the sequence at the other end. As you can see here, there is an insertion sequence. There is inverted repeats. There is inverted repeats, or there is a transposes genes. Means there is a problem in their sequence. So insertion sequence, we can say that they can copy themselves and insert themselves into a chromosome or a plasmid. They do not encode resistance, but they function as a sites for the integration of other resistant encoding elements like plasmids or transposons. What is meant by plasmid? These are the extra chromosomal genetic material which is present in the cytoplasm, and they carry genes for coding resistance. They carry genes which codes for the resistance. We can call it as a plasmids. Now these are the various efflux proteins in a cell membrane. These are the efflux proteins, efflux pump. They will expel all the drug from the bacteria or from the microorganism. So these are the examples of ATP binding cassette transporters, resistant nodulation division exporters, small multi-resistant resistance systems. These are the various examples of the transporter that we have. Then there is a cross resistance exhibited among chemically and mechanically related compounds. They will show cross resistance in chemically related or mechanically related compounds. When microorganisms develop resistance to one drug, it is also resistant to the other drugs of the same category or same group, even when they are not exposed to them. Even when they are not exposed to them, one microorganism will develop resistance to the one drug. It is also resistant to the other drug because they are chemically related or mechanically related. So acquisition of the resistance to one antimicrobial agent conferring resistance to the another to which the organism has not been exposed. Resistance to one tetracycline means it shows resistance to all tetracyclines like doxy. If that microorganism shows resistance to one tetracycline, that means it will shows resistance to all other tetracyclines like doxycycline. Partial cross resistance is seen among the aminoglycosides also. Now, there is unrelated drugs like erythromycin and lincomycin. They may show partial cross resistance. Partial cross resistance, either there is a one way or two way. One way means neomycin resistance by Enterobacteriaceae makes insensitive to the streptomycin, but streptomycin sensitive organisms susceptible to neomycin. That is the one way resistance. Neomycin resistance to the Enterobacteriaceae will make insensitive to the streptomycin, but streptomycin sensitive organisms they are susceptible to the neomycin. Two way means tetracycline and doxycycline. The organism which shows a resistance to the tetracycline or doxycycline, they will show resistance to all. Means there is a vice versa. If they are resistant to tetracycline, they show resistance to doxycycline. If they are resistant to doxycycline, they show resistance to the tetracycline. So there is a two-way bacterial resistance. Then there is a superinfection. Superinfection means appearance of a new infection as a result of antimicrobial therapy. Appearance of a new infection as a result of antimicrobial therapy when use of most antimicrobial agent cause alteration of the normal bacterial flora of the body. It will alter your normal bacterial flora. It will kill your normal good bacteria. So normal bacteria contributes to your host defense mechanism by secreting the bacteriocins. This bacteriocin inhibit the pathogenic microorganisms and pathogens to compete with the normal flora of nutrients. So it will going to alter your normal bacterial flora. So lack of competition may allow normal non-pathogenic organisms to proliferate and invade. What happens? There is a lack of competition and that may allow the normal non-pathogenic organism to proliferate and invade. So because of that, when you are using broad spectrum antibiotics for a longer period of time like tetracycline, chlorphenicol, ampicillin, clindamycin, and even they when combined in case of immunocompromised states, in patients of immunocompromised individuals, so that may cause superinfection. Superinfection means appearance of a new infection when you are using broad spectrum antibiotics for a longer period of time. So if you are using that broad spectrum antibiotics in case of immunocompromised states, if you are using corticosteroids for a longer period of time in patients of leukemia or malignancy, means if you are treating that person with the anti-cancer drugs, immunosuppressants, in patients of AIDS or granulocytosis, neutropenia, diabetes, SLE, vasculitis during stage of flare. So there is appearance of a new infection in case of oropharynx, lower GI tract, genitourinary tract. These are the appearance of new infections, and the organisms like Candida albicans, Clostridium difficile, they may cause pseudomembranous colitis, they may cause Candida infection. So we have to treat them accordingly. By using drug of choice, various the drug that we have to use. Then combined use of antimicrobial agents. Combine use of antimicrobial agents to achieve the synergism. Means we have to combine two bacteriostatic drugs. When you combine two bacteriostatic drugs, that will act like a bactericidal. Addition of two bactericidal drugs to increase the efficacy combination of bactericidal with the bacteriostatic to reduce the severity of the various adverse effects, to reduce the chances of antibiotic resistance. Means you have to use the combination therapy to prevent the emergence of resistance, to broaden the spectrum of antimicrobial action for the treatment of mist infection, initial treatment of severe infection. When you are using the drug topically, you can mix those drugs. So, prophylactic use of antimicrobial agents. Prophylactic use of antimicrobial agents. In case of tuberculosis, isoniazid along with rifampicin. We use the combination therapy, HRZE. We all know that. HRZE, H means INH, rifampicin, pyrazinamide and ethambutol. The drugs that we use in combination to prevent the emergence of resistance. In case of Mycobacterium avium complex, we use the clarithromycin. HIV infection, we use the combination therapy of zidovudine, lamivudine, indinavir. In meningococcal meningitis, we use the rifampicin. Gonorrhea, ampicillin, ceftriaxone. Recurrence of the urinary tract infection. In case of malaria, mefloquine, chloroquine. Influenza, amantadine, plague, doxycycline. Pneumocystic gyrovecai. Clotrimazole means all those drugs we have to use the prophylactic therapy whether the infection is developed or not. You can give the as a prophylactic purpose. Pneumocystic gyrovecai, clotrimazole, it will prevention of infection in high risk situation. Means in case of dental extraction, tonsillectomy, endoscopies in patients with shunts, immunocompromised patients, we have to use the prophylactic antimicrobial therapy. So this is all about the general principles of the antimicrobial agents.